Yeah. Thank you. It's a great honor for us to present our recent work in the prestigious scientific meeting. In this presentation, I'd like to convince you how important the role of information and communication technology, ICT, in the disease field is going to be. This is my declaration of interest. Without a doubt, a good therapeutic goal of STEMI should be to minimize the whole myocardial ischemic time for better survival and prognosis. In contrast to the mature in-hospital care by primary PCI, pre-hospital care is not yet standardized and remains to be innovative. ICT should be more extensively utilized in the face of its recent huge progress. This scheme represents ACCFHA guidelines for STEMI 2010, and it says that goal for STEMI patients is to achieve reperfusion within 120 minutes from symptom onset, as well as 90 minutes from EMS to PCI. And what is the key? Guidelines recommend that pre-hospital 12-lead ECG should be crucial, which allows us to activate catheter before arrival by bypassing these two steps and leads to suppressed loss of myocytes. However, its protocol and methodology is not yet standardized or defined, allowing us a lot of incomplete ways for pre-hospital ECGs, from costly high-tech live streaming to assessing ECG by non-cardiologist sites. So this is defined as class 1B in this guideline. To establish pre-hospital 12-lead ECG as a standardized format, we developed a mobile cloud-based 12-lead ECG system based on modern mobile ICT. We evaluated clinical efficacy for STEMI patients by conducting 2 clinical trials in the real emergency medical service (EMS) and critical care settings. We needed to consider what are the specifications required for the care of STEMI. We decided the following factors in terms of priorities for STEMI patients clinically. Precise 12-lead ECG is absolutely necessary for accurate diagnosis in contrast to limb leads only or fax resolution. And fixed image transmission is sufficient for diagnosis. And no live streaming is necessary since AED is now popularized. The cloud computing has a potential to apply this system to a variety of clinical settings in contrast to email system that has a security concern. The popular mobile devices are suitable to easily achieve usability, reliability, simplicity, and reduced cost. Taken together, we developed the mobile cloud-based system in cooperation with the Labtech company in Debrecen, Hungary. System cost is currently below half of the conventional one. And this is the schematic diagram of the whole system, which consists of compact ECG unit connected with Bluetooth with Android tablet with mobile app carrier spine and cloud-based server. ECG is precise enough and electronically available for viewing, printing, and exportable data for electronic medical records. We first performed a transmission experiment to look at echo back time from Android app to PC by cloud with 3G cell phone network in various places, like this Tokyo, Shizuoka, and Hokkaido, Japan. ECG was successfully transmitted at a rate of 100% from any place as long as a mobile phone network was available, not only from streets and roads, but also from fields, trains, inside the tunnel, or on the ferry of Tokyo Gulf around 20 seconds. So we conducted the first clinical trial to investigate whether EMS utilization was optimized with accurate risk evaluation by instant ECG sharing. We selected EMS resource-limited area of Hokkaido and the North Island in Japan, where population is 100 as sparse as Tokyo, characterized by small number of medical facilities in over 100 kilometers in radius, where EMS is not satisfactorily provided. Mobile cloud ECGs were installed in 5 clinics, local clinics. When suspected patients were referred to center hospital, ECG was transmitted and determination transfer was made, depending upon emergency risks indicated by clinical presentation as well as the diagnosis of ECG. This is a result table showing the distance, total number of cases, and actual emergency transfer from 5 local clinics. Taken together, actual transfer rate could be restricted to 33% in average, which is less than the historical control of 60%. Average distance of transfer was 67 kilometers in average, leading to the optimization of EMS utilization, because long-way ambulance transfers should be limited in local EMS resources. We conducted another single-center clinical trial in the critical care center at Kitasato University to investigate whether MCECG can improve parameters regarding clinical outcome of STEMI patients. This center is located in Sagamihara City, the densely populated suburban area of Tokyo. Patients of acute onset of chest pain suggestive of MI were transferred either by doctor car equipped with mobile cloud ECG here, or by conventional ambulance here, depending on its availability on time. In mobile ECG group, a doctor on site uploaded ECG to cloud server. At this point, cardiologist in the center make a decision to call PCI team and direct to activate cath lab in advance of the arrival. By contrast, in the conventional group, they are simply transferred by a regular ambulance, and the diagnosis was made just after the arrival. For 2 years of study period, 55 suspected MA patients were transferred by Dr. Pearl, and 23 patients excluded, and finally 32 patients were included in the MCECG group. During the same period, 132 patients are transferred by ambulance. Out of them, 76 patients were included in the conventional group. This was a non-randomized case control study, and a comparison was made between both groups. In terms of the demographics, there was no difference. As you can see in this table, PCI primary success was achieved in 100% for both groups. Importantly, door-to-bone time for STEMI was significantly shortened in mobile cloud ECG group as compared to conventional group by about 18 minutes. In the following clinical course, peak CK and CKMB was not significantly different between both groups. In summary, we developed a mobile cloud-based system to share 12-lead ECG instantly. MCECG was effective for accurate risk evaluation in remote settings. Door-to-bone time in STEM patients was significantly shortened with MCECG. Collectively, MCECG was effective for both EMS and patient's clinical outcome. Despite study limitations, hospital SCT solutions such as mobile cloud ECG provide a standardized framework to improve clinical outcomes with STEM. Further research and development for this aspect of ICT is to be promoted in the context of clinical effectiveness. Thank you for your kind attention.